what if you could take the drug out of the trip? In other words, recreate a psychedelic-like experience without reference to a psychedelic drug itself.
Hi, I'm Elizabeth Koch. We all live inside our own personal, private perception box, built by our genes and the physical, social, and cultural environment in which we were born and raised. In this podcast, we explore how although the walls of this mental box are always present, they can expand in states like awe, wonder, and curiosity, or contract in response to anxiety, fear, and anger. I'd like to introduce our esteemed hosts, two incredible and distinguished minds. Dr. Heather Berlin, professor of psychiatry and neuroscience at the Icahn School of Medicine at Mount Sinai in New York City, and Dr. Christoph Koch, chief scientist for the Tiny Blue Dot Foundation and the current meritorious investigator and former president of the Allen Institute for Brain Science. Welcome to the Science of Perception Box.
Hi, everybody. Welcome to Science of Perception Box. I'm your co-host, Dr. Heather Berlin.
And I'm your co-host, Dr. Christoph Koch.
So every week, we feature an aspect of the Science of Perception Box, highlighting the latest research together with our expert guests. This week, we're exploring the powerful research around psychedelics and dream states in the practice of anesthesiology with a researcher and doctor who has been as fascinated about consciousness as we are. Dr. Boris Heifets is a board-certified anesthesiologist who specializes in providing anesthesia for neurological surgery. He's practiced at Stanford since 2010. In addition to treating patients, Dr. Heifetz also directs clinical research and basic neuroscience. His research group studies how new, rapid-acting psychiatric therapies like ketamine, MDMA, and psilocybin produce lasting changes in nervous system function, behavior, and therapeutic outcomes. But first, we want to share our own connection to psychedelics. So, Christoph, how have psychedelics helped you expand your perception box?
They made me lose a sense of self. They made me lose my sense of body, of an external world, but there was still consciousness. And they made me lose my fear of death.
Well, that's pretty profound.
Yeah.
So do you think you're a more relaxed person now?
Yes, certainly.
You seem very relaxed. Well, Boris, thanks for joining us.
Thanks for having me.
So how did you become interested in psychedelics as an anesthesiologist?
So I became interested in psychedelics well before I became an anesthesiologist.
I see.
The question is, how did I become interested in anesthesiology as a psychedelics explorer?
You mean a psychonaut?
Well, I've done some research on the topic before becoming a doctor. When I was towards the end of my PhD training, so I did an MD and a PhD at Einstein in New York, I had this question of well, how am I going to apply this? What we're doing is we're looking at synaptic responses in brain tissue. We're looking at the inner workings of how circuits function in the brain. And I didn't want to lose that, right? And I wanted to pick a specialty that would allow me the most access to that kind of thinking and that kind of environment. And, not to mention this background interest in psychedelics. I think when I started medical school, my mom told me, drop it. You can't have a career. You can't have a career studying psychedelics. It's hippie science. It was, this was in 2000, probably good advice. But when it came time to pick a specialty, I was thinking about psychiatry, neurology, neurosurgery, and anesthesiology. And the closest I could get to applied neuroscience was actually anesthesiology. You give a drug, and you see its effect on the brain, the body, on consciousness itself. And that, to me, it never gets old.
How do you know that consciousness is gone as compared to they're unable to talk and they're unable to signal that they're still there? How do you know they're not present?
So we have a lot of interviews with patients after surgery that, can attest to that, is that what's kind of remarkable about anesthesia is that it's not like sleep. And when you close your eyes as you go off to as you are anesthetized for surgery, when you open them, many patients will feel that no time has passed. It's very different from when you wake up. You kind of have an intuitive sense of how long you may have slept. So that's already one difference, just at the level of what the patient experiences. One of the earliest concerns for anesthesia, as we were developing anesthetic techniques to keep people immobile and pain-free and amnestic, right, during surgery, is there's something called the Bryce questionnaire. What's the last thing you remember before going to sleep? What's the first thing you remember when you wake up? And did you have any dreams during anesthesia? Do you recall anything? And that's basically how we set standards for what depth of anesthesia we use.
So how often does it happen that, I guess, depending on the type of anesthesia and the duration, that people do recall something that does relate in some way to something that did happen in the OR?
So it's around 1 in 1,000. So awareness under general anesthesia, even with EEG monitors. So, we're monitoring brain function. We're getting a sense of the depth, but we're clearly not getting the whole picture because every once in a while, a patient will recall something. Now, I want to put a qualifier on that before, nobody ever has surgery again after listening to this podcast. I've seen one case like this, and in an elderly woman, not who I would have expected. And though the thing she said was everything was so far away that I was like, everyone was touching me really softly. But she was recalling conversations in the OR. So there's a deep disconnection, but she was able to maintain some sort of input from the real world. So that, again, that's 1 in 1,000.
And no pain, right? Because pain is controlled
She didn't
separately.
complain of pain. She didn't complain. It was a little bit distressing to her because she knew what happened, but she wasn't paralyzed. The thing that I was most worried about is, did you feel trapped? And, thank God she didn't. And that's, again, advances in anesthesia have allowed us to do surgery without paralysis, even in some cases. So again, that's maybe a topic for another time, but it's a rare complication that we do worry about. And again, that was the early concern of anesthesiologists, is that we want to make sure that consciousness is gone, right? Deep disconnection, disconnected unconsciousness, that's reversible at the end of surgery. Now, in the last 20 years, anesthesia has gotten a lot safer. We've started innovating things like nerve blocks, for example. So now we have a little bit more room to think about, how much do I want to sedate this patient? What kind of experience do I want to provide? And that's where things start to get a little bit interesting.
So before we get into the research, can you tell us a little bit about how psychedelics work in the brain and how they can be used as a therapeutic intervention?
Sure. So this is a very hot topic right now. And, when we talk about psychedelics, what are we talking about? There's the classic psychedelics, LSD, psilocybin.
So the classics.
The greatest hits. And then there are other drugs that are, I would say, psychedelic adjacent, that a lot of people will identify psychedelic-like properties in these drugs like MDMA, which is nearing approval potentially for PTSD. Ketamine.
Assisted therapy.
Yes, MDMA assisted therapy, which we're going to return to that point, I hope. And these drugs are not, they don't have the same perceptual effect, but they clearly are, they are acutely psychoactive in a profound way that is very memorable and unmistakable. And what ties all of these together and what has, led to this explosion of research and excitement is that when you provide a space for people to have a powerful psychoactive drug in a safe setting and just let them, let their mind wander, things come out. Things that, if you have PTSD, if you have painful memories, if there are things that you haven't been able to resolve in your life, what people talk about is getting a new perspective. Whether it be like, what is going on in my body? Where is this pain coming from? Or, who is this person who's, always depressed and, pessimistic? This perspective shift is something that people across these drug classes will talk about. And to me, that's what defines this broad class. They're acutely psychoactive, powerfully so. Their effects are rapid. That perspective shift, or however you want to call it, it's rapid.
Change in a perception box.
You can put it that way as well. And finally, the effects are durable. This is very different from modern mental health care. You don't take these drugs every day. You have long after the ketamine or the MDMA or the psilocybin has cleared your bloodstream, you're still feeling those positive effects. This is a sea change in how therapy is delivered. And I want to emphasize again, it is far more complex than just giving someone a drug, putting them in a room, while they, have their experience.
So it's the synergistic effect between the actual, physical effects of the drug in the brain and this psychological effects.
I'm
or
going to
impact.
challenge that. I think that's actually one of the biggest debates right now. And it has implications. Is it the drug or the trip that's responsible for these therapeutic benefits?
Right, because you get the same benefits
Assuming that
without...
conceptually, A and B, empirically, experimentally, you can separate those two.
That's exactly it, right? That's why there's the debate, is right now all we're looking at is correlation.
And so tell us more about this debate.
Mm-hmm.
It boils down to this, is you can think of, the complexity of psychotherapy, you can simplify into three basic stages. There's preparation, which involves, setting expectations, building rapport. There's the drug experience itself, a possibly 8-hour extravaganza sometimes.
24 hours.
Or 48. It depends, the dose is everything. And then there's the integration, making sense of what happened and trying to incorporate those changes into your life.
Which can take weeks, right?
And in trials, that's how long it takes, is that you have weeks of after therapy. So, the inclination, based on decades of experience in, pharma, is, well, it's got to be that little crystalline entity in the middle of all of this that's driving these effects. But in reality, as you pointed out, you cannot possibly attribute to one factor the therapeutic change unless you can independently manipulate them, right? And this is where the science comes in. I'm going to put in a brief plug for why any of this matters. There are people who, believe, not without cause, that it's enough that it works. Why get so bent out of shape about how it works? It's just enough that it does work. And I would answer to that is, one thing that anesthesia has brought me in contact with is some of the most advanced medicine on earth. And when I see, one of the most magical moments in residency, and I don't mean to gross you out, but watching a transplanted heart get put into someone's chest, fibrillate, and then convert to sinus rhythm.
Crazy.
It's like watching birth, or the earth being born, or a total eclipse. It was it was just awe-inspiring. How did we get from someone living for 50 hours in the 60s after a heart transplant to 80% at 5 years? This is amazing. It's by understanding the risk and understanding the mechanism.
I mean, science. This is why science works.
And so that, to me, is the question. If a therapy is truly potent, by definition, it carries risk, right? And when you think about the early days of chemotherapy in 1975 was almost a death sentence in itself. 30 years later, you have the first rationally designed kinase inhibitor. That blew my mind in 1999, Gleevec. That cured leukemia. And, that's, you take something that has, it's a powerful chemotherapy, was powerful and crude, and we learned something and innovated and distilled it down to something, something highly effective and targeted. I'm not sure that CNS, that psychedelics are going to go that way, but there's a pretty strong track record in every other field of medicine for this approach.
There are also strong motives in the industry to pursue that, because that's what the entire medical system is based on. You give one little therapeutic intervention that the FDA approves, that you can then, sell to everyone, that works. But in this case, because this is the most complex, you're talking to the most complex piece of active matter in the known universe. And I seriously doubt, having studied my entire life, that any one drug will be a magic bullet that cures whatever existential problems that brain or that mind has.
I'm going to turn that on its head, in that I completely agree with you. But how do you, without demonstrating the centrality of, like, my overall overwhelming sense from all the work I've done is that we need to center the experience.
My biggest question is whether it's the molecule itself or
Or
you
the
need the
experience, or both.
psychological experience. And can you isolate the psychological experience so they don't have to even take the drug? Or are there other ways to get to that transformative experience?
Yeah, that's what we're trying to develop, is that psychedelics pose really fundamental challenges for, randomized controlled trials. Let's start with that for a second.
Right, because you're on the drug once you're on it.
And so why would that be a complication?
So it introduces all kinds of biases in that, the randomized placebo-controlled trial was designed for antibiotics and blood pressure medication.
But the power of not knowing whether you're on the drug or not is really to get around the placebo effect thing. Is if there's a certain amount of impact that the drug can have, just thinking you've taken the drug, that can have an effect. And
but probably not for TB, right? That's the logic behind
there's some
it.
things where placebo effect, we should be so lucky to have a cancer placebo effect, right?
Right.
People do not often spontaneously remit, just on the strength of their belief. Although, there are all kinds of stories. But it's important because, think about it from a patient's point of view. You have read Michael Pollan's book. You are fascinated at the potential of psilocybin. You have outcompeted 1,000 other applicants to be in a study on depression. You have already won a lottery, right? Now you go into the finale.
And you've already failed two other trials,
You've
right?
already failed two other trials, and I think this is going to be it. And so you have an expectation. It's obvious that if I get the drug, I'm likely to improve, because look at what all of these smart people say. And now comes the moment of truth. You're in, your boyfriend, your girlfriend drives you, maybe you fight about it because you've been so kind of persistent in your pursuit. You go through a lot of trouble to get to that room, to that therapist room, and then you take the drug, and an hour later, there's either a moment of confirmation and acceptance and being seen and being in an elite group of people on Earth who've been in a psilocybin trial, or a moment of betrayal where, why did I spend all of this effort to be in the placebo group?
Because nothing happens
because
to your
it's
mind.
obvious. It's to most, it's such an obvious psychoactive effect. So, if you it's like winning the lottery. What is the effect of winning the lottery? And you tell me, what does that have to do with depression? Like, I guess like winning the lottery could be a short-term antidepressant, but that's sort of the heart of it.
And so because they've been told and they read that these are wonderful drugs, they were less likely to be depressed afterwards. That's what you're saying. That's what the placebo effect is.
Exactly.
But because they know if they're on the placebo or not with psychedelics, it's very hard to control for that. So do you have a way that you're trying to get around this?
So again, if that's one of the biggest problems facing psychedelic medicine, is identifying a drug-specific effect, it requires some innovative solutions. And I want to talk about a couple. One is efforts by David Olson and Brian Roth, two great chemists, and many others who are re-engineering the molecule itself. They're basically trying to take the trip out of the drug.
Christoph's thinking that's no fun. Where's the fun in that?
But
They want to take the fun out of everything.
This is the science.
Okay.
That to me, it's crucial,
Okay.
right? Like, you have to test. How can you
Assuming
not?
you can do that.
Let's just say for a minute it's possible. You will get some answer there. Can you just encode resilience, through biochemically without anybody noticing, right?
What about giving the psychedelic while somebody's under anesthesia and they have no
Heather,
experience?
That happens to
Funny
me when we
that
do.
you asked.
I'm so glad you asked. So it requires a lot of different approaches, and this is the one we took. Now, I'm an anesthesiologist, and it's hard to escape the idea that, you have all these people that come in from all walks of life, many with pre-existing depression, PTSD. That's usually not what we're focused on. We're usually focused on getting them through surgery. And we saw this as an opportunity, is that patients are put on, they're put under general anesthesia. And while they're anesthetized, like there's no there there. They're not there for it, right? That's kind of the goal. So what if we gave a psychedelic class drug like ketamine during anesthesia? So it's important to know that this is on a background of general anesthesia with not using ketamine as an anesthetic. We're using drugs like propofol, drugs like sevoflurane. These are standard anesthetic cocktails. And we're getting everyone to pretty even cruising depth of anesthesia before we give them either ketamine or placebo.
So they're deep. So if you do a surgical cut, they don't.
That's the goal. They're there for surgery. Now, part of how we were easily able to get approval for this is that ketamine is an anesthetic. It's an anesthetic adjunct. So we were, in patients for whom there's what we'd call equipoise about, ketamine is kind of you don't need to give it. There's nothing in the case that screams out this patient should definitely get ketamine. We're able to do this trial. And we ran it like a psychiatry trial. And this is with actual psychiatrists like Laura Hack and Alan Schasberg, who helped, quite a bit on this study. But we ran a psychiatry trial in the operating room. And they give 0.5 milligram per kilogram over 40 minutes to minimize the psychoactive effects.
But in a regular awake person, there would be strong psychoactive effect with this dose, right?
Yes, and that's what we've seen. We've done worked on a trial with Nolan Williams where we were giving ketamine to awake patients.
At this dose?
At this dose. And patients they'll have what's called, they'll dissociate. They'll get into a dreamy state. They might hallucinate. If you listen to what they say, there is a lot of overlap with psychedelic like effects. And let's put that on pause for a minute. But that's the trip of ketamine that we're actually trying to see, do you need that in order to benefit from ketamine?
So now you give them this dose, which normally in a wakeful person, they would have a sort of psychedelic effect, but they're under anesthesia, and you have it placebo-controlled, meaning you're going to give them another substance that's not ketamine, or just give them no ketamine?
We just give them normal saline.
Okay.
That's a fluid with the same volume, and I guarantee you the patients were not aware. Everyone was blinded in the study.
So they wake up, and what's the measurement? What do you assess?
So again, we want to copy what's been done before. We're not reinventing anything. We're using a standard scale of depression called the Montgomery-Åsberg Depression Rating Scale. It's a clinician-rated scale, meaning if let's say you're my patient, I'll ask you questions about, tell me about your fatigue levels, or, how's your appetite? And there's kind of standard degrees of
severity, but you're expecting there to be an effect right away, right after the surgery.
That's the beauty of ketamine.
SSRIs you give a patient, and maybe 6 weeks later they say you'll feel something maybe, and it's very hard to make the connection between the drug and the impact. But with ketamine, they give it in the psych ER, and it really can knock out suicidality.
And there's nuance to everything, but essentially yes, that's the design of this therapy, is that it's rapid acting antidepressant.
So you give them this measure of depression right when they come out of surgery. You don't know who's had it and who hasn't.
So we waited a day. There's a lot of things that happen right after surgery.
Yeah,
but again, we're copying other studies where you have the peak effect, the peak antidepressant effect of ketamine is 1 to 3 days after infusion, long after the drug is gone, which is where we started this description. And that's where we're taking our primary measure, is looking at depression scores in the 1 to 3 days post-infusion, post-surgery.
And what you found was?
Well, all of the patients who got ketamine did great. They, 50% response, 30% remission from patients, many of whom had treatment-resistant depression.
So
now, what about the other patients?
Well, so the placebo group also did great. 50% response, 30% remission.
So it's remarkable. So you're saying whether or not they got the ketamine, both
groups on average showed the same degree of improvement. You could not separate them. The key here is that both were massive improvements. And there's a couple fine points here, because I got a lot of, wasn't exactly fan mail about the study, but people who looked at the study say, are you saying ketamine doesn't work? And there are a couple points to bring out about this. And the first point is, what was the patient experience like? And this, you'll see how this is important in a minute, I think. And again, keep in mind this very large placebo effect that we saw that we were absolutely not expecting. From a patient, let's say you're coming in for surgery. For 20 years, you've been dealing with a lot of trauma, the holdovers from a rough childhood, et cetera. And now you go see your surgeon, and do you think your surgeon is going to ask you about your mood? We can venture a guess to say usually not. It's the rare surgeon that has time, because there are other priorities. So from your point of view, you're getting something in your email saying, we care about your mental health and recovery after surgery. Would you be willing to fill out the survey and talk to us? That's our first contact with the patient a few weeks before surgery. And then you come in, you get a consent. It's about an hour long where you hear all about the study. ketamine. We think it's an antidepressant. In other circumstances, we're wondering whether this has therapeutic value during surgery. Now you come in for a 2-hour interview with, 4 of us, a nurse, myself, a research
2
coordinator.
hours interview, just as part of the work of
Yeah,
the study.
we want to know everything, and from a patient.
So you're sort of priming. First of all, they're getting more attention. You're talking about their mood. You're priming them to this drug might really help your depression.
Exactly. And there have been studies of depression during surgery before, and I don't think they went all out like this. We were looking for a particular type of patient. I was so happy to get each one of them, each of these 40, that, we really, we learned a lot about all of them. And so 2 hours where, we heard about their trauma, their mental health history, their physical, their physical history. And then, the morning of surgery, I wanted to make sure things go off without a hitch. In many cases, I held their hands as they went off to sleep, right? I mean, these patients were precious to me, and I was not at all thinking at the time, my God, what kind of placebo effect I'm engendering. And let me stop there for a second. Why was I so blithely unaware of the possibility that we might induce this massive placebo effect? It's because think the broader context is surgical anesthesia. Surgery and anesthesia are associated with a higher risk of heart attack, stroke, cognitive dysfunction, kidney injury, lung injury. Actually, all of our literature points to all these things getting worse after surgery.
Nice.
That and putting people at risk for opioid use disorder. So that's what I came in with. All right. I was not thinking that placebo would be a problem or that this study would even be about placebo.
So the placebo was really a surprise to you.
It was a big surprise.
Well, this is my question. I mean, what is the takeaway here? Is the takeaway that for the effects of ketamine, you don't need the psychedelic effect of ketamine for there to be an improvement?
The takeaway is this: it's in the placebo effect. We can't say much about ketamine in this trial, but what I think we can say something about is all of the trials going on in the psychedelic space. Again, I painted that picture for you of winning the clinical trial lottery, right? And going through that process and all the confirmation bias that might go along with it. There are a lot of non-drug factors there. So inadvertently, just the structure of this trial with preparation, a big central event, surgery and anesthesia, and then, close follow-up in the aftermath, we had replicated a lot of the key elements of most psychedelic studies and driven a placebo effect that is enormous.
Well, in some ways, this is really good news. I mean, first of all, where is this published, this paper? In
Nature Mental Health.
Okay. So I think everyone should take a look at the paper, but it's a warning to say, look, we really need to structure these psychedelic studies in a different way. However, it's really positive to say that, like, for instance,
your mind can change your body.
Yes. So we don't need the drugs.
We need something. These patients went through something, and I think that's a key part of this.
An experience, though. It was an experience.
Well, yeah, but they need this belief. If they don't have this belief, so you have to tell them that this thing is magical, whether it's a ceremony or dance or
but it's got to be, you can't
molecule.
Just tell them. You need good placebo. We had really good placebo. We had the best placebo.
Tell me, what about does the belief that the patient, because you must have asked the patient, did you think you got it or did you think you were in the placebo, and how does that affect?
So, as I said, we weren't expecting this massive placebo effect. So, and this was we started the study in 2019 before a lot of the writing about expectancy had come up. So we didn't ask people until the very end of the study, which group did you think you were in? I will say this is like one of the maybe the only truly blinded study of a psychedelic class drug. So that was a small victory. But when we asked them what they thought they got, so nobody knew, first of all, but in talking to them, my conversations with these patients, if they got better, they attribute it to the ketamine. They said, well, I must have been in the ketamine group because I feel better, which suggests that they had some prior belief, right? If you wouldn't say that you got ketamine unless you believe that ketamine is therapeutic.
Surely there must have been some people who believe it, or maybe not, who believe they were on the placebo.
And those are the ones, because they didn't get better. They didn't get better. And they're like, well, I must have been in the placebo group. So what that shows, if anything, is that we did a job, unwittingly or not, a good job of instilling a sense of hope that this has the potential for therapeutic benefit.
And I think that's how you conclude in the last paragraph of the paper. This is called conventionally, the short name of this is hope.
Yes. So there's a dangerous side to it. Not dangerous, but we can draw some of the wrong conclusions from this work. One is that the convention, placebo is an old word, and it literally means like I please.
To please.
Right. So one of the kind of the awkward things is if someone gets better after getting placebo and then you tell them they got placebo, it's more than a little awkward. They're like, well, all that stuff I said, well, in the throes of placebo, like, was that all, like, it wasn't real. Right. And so it's very, people need to feel seen, need to feel heard. And, that idea that placebo is just something that you trick children with. Right. We have to dispense with that idea.
No, I think we need to harness the placebo. I've always said this, harness the placebo effect and
It's your
use it
mind.
in medicine.
Yes.
Exploit the placebo
and
effect.
good doctors do it.
Yes.
And real in
That's why
psychedelic
you
therapy.
have white coats. That's why you have Dr. Boris Heifets.
Well, I mean, this is
Well, because if I believe you, just like a shaman, if I believe you are the shaman, then I'm more likely
That has to be part of it. And there has to be a strong experience at the center. I had a bar mitzvah when I was 13. My father said, today, my son, you're a man. And I can tell you, my voice did not drop, but I felt different. People looked at me different. They treated me differently. And that's right. I mean, and how does that happen? It's not a person in isolation. It's certainly not a drug effect. It's a door that you walk through that is held up by, the collective understanding of the community that surrounds it. And that is a very devilishly hard thing to study with conventional scientific methods.
a lot of it is the power of suggestion, right? If they come in and they're depressed and, or they're low, I'm never going to meet anybody, I'm never going to find anybody. You give them this sort of hope and they believe you because you have all these credentials and stuff, like rather than me just giving my friend, some good advice and, they take your, I really feel like you're going to meet someone. I really have, I trust that's, and then they start to believe it because someone in a sort of authority position gives them that hope. It's not about the SSRI they're taking, but studies do show in conjunction, you get some powerful effects from the SSRI, some from therapy. When they work together, you get this synergistic effect. But I want to just talk about, because I know there's other research you do in terms of dreams and sort of inducing dream-like states with anesthesia that I really want to.
So going with this theme of experience, in this study that we're just, wrapping up, the experience, they all went through something. It's not the experience on drug, but it's the larger experience of being in the study and going through a door, right? Having surgery and coming through the other side.
Was there any therapy afterwards?
No. That's we like every other ketamine study, included no therapy.
And how long did you?
2 weeks.
And so you didn't track these people still?
Not formally. I mean, I kept up with some of them, and some of the stories, I'd love to share some of them. It really made me question whether I should be in science or not when I couldn't tell, like, is this woman in the ketamine group? Because how do you get that kind of transformation without something to account for it? Of course, she's in the placebo group. Mm-hmm. So there's another way to look at this. And, we're coming back to this theme of, preparation and the drug, the day of the dosing, the drug and the trip, and then integration, and really focusing on the drug and the trip, which you could either take the trip out of the drug, and we've now talked about a couple ways to do that. What if you could take the drug out of the trip? In other words, recreate a psychedelic-like experience without reference to a psychedelic drug itself. That would be a pretty interesting way to test this idea of how special is the serotonin to a receptor, right? And there's just some very exciting research.
But now we're talking about how do you create
how do you regenerate exactly
hallucinations without the psychedelics?
So wouldn't it be an interesting test if we could induce a psychedelic-like state without a psychedelic and get some of the same physiology, descriptions of experience, and therapeutic effects? Would that maybe turn on its head the idea that there's a powder at the center of all of these therapeutic effects? And that's almost by accident what we've stumbled upon working with anesthesia and dreams. And I have a colleague, Harrison Chow. He's I was going to say an artist. He's an anesthesiologist, but this is the art of medicine. He spent many years in private practice. Minor procedures. Patients would come in for, hernias or, endoscopies, minor stuff. And he would try and make the experience as pleasant as possible. So he would do this thing where he would watch the EEG monitor and look for what he thought was dreaming. And then patients would wake up and say, I had the best dream. I had the best sleep I've ever had. But as you emerge, one of the things that you can notice if you really pay close attention to the EEG, right? This is brain state monitoring.
So you're watching them as they come out of anesthesia and the waves start speeding up and they're getting higher frequency.
Yeah. So when he came to Stanford, my chair put him together with me because he knew I was like a psychonaut drug nerd into non-ordinary states of consciousness. And if you should talk to each other and like maybe figure something out. It was a great partnership. Harrison is really like into the idea of making anesthesia more pleasant. I'm, a little bit more scientific, and I was very skeptical at first. So we agreed we're going to get a portable EEG, a SedLine, the same, a kind of couple leads. We have a team, includes a psychiatrist. We are going to do, interviews, diagnostic interviews, and we're going to follow these patients. I want to know, is what you're saying, are you bullshitting me, or is this real? Is there something there? And not long after, we had our first case. And this is a case of a woman, this was published 2022, where this woman, she had been attacked at close quarters by a relative with a knife. Horrifying. As you might imagine, she had nightmares, right? She went to the emergency room and they said, go to Stanford, get your hand fixed. And, in the intervening time.
The hand got injured.
Yeah, exactly.
Defending herself. So the surgery was to help
the surgery was for her hand. And she, in the intervening 2 weeks, she's basically a non-functional human, right? She's hypervigilant. She's, having difficulty.
PTSD. She has severe
PTSD. Due to the time frame, we call it acute stress disorder. But this is somebody who would, more likely than not, we would be worried she would go on to develop PTSD. So she's in the pre-op area, right? She's there for her hand, and Harrison finds her again, still, that's all she can talk about. And she's really, hard to reach. And they, again, talking about like innovations in anesthesia, they put her arm to sleep. She gets a nerve block, and Harrison does his dream thing.
Wait, so is her arm anesthetized?
Yeah, her arm is anesthetized, so she doesn't need to be so deeply anesthetized that she can't feel.
When you say the dream thing, it's just that you're controlling the amount of propofol.
And watching
the EEG and getting her into this sort of sweet spot where he knows that the dreams occur.
Yeah.
How long is his state of dreaming in this patient?
About 10 minutes.
Oh, very brief.
Relatively brief, but there's a lifetime in 10 minutes.
Yeah.
So what she says immediately upon waking is the nightmare. It was there again. I had the nightmare again, and it was looping just like it always does. But instead of rocketing her into consciousness, right, which is what a nightmare is, by virtue of this anesthetic suppression, she stays in that state, and she actually, in her dream, moves past the attack. She, in her dream, goes to the emergency room, goes to the operating room. She's back home running errands with her hand healed.
All in this 10 minutes.
All in 10 minutes, a lifetime in 10 minutes.
Just to go back for a second, just because in terms of therapy, often like I'm working with patients who've had trauma, and the idea is to help them, work through the emotions, is to sit with the thing that makes them anxious or uncomfortable long enough. Yeah, exposure long enough to get through it and resolve it and then move on. But often when people, as soon as they get, the cortisol comes or whatever, they want to avoid it and they never get through that. So maybe that being in this dream state allowed her to get past the anxiety part of it enough so that her brain was able to kind of process it.
We're thinking along similar lines. And so first of all, we followed her for a day, a week, a month, a year. And what is still remarkable to me is she's able to just talk about this attack. No nightmares, like, she's functional. She's a functional person who has recovered from trauma.
You think due to a 10-minute dream?
Well, we've done it now about 600 times.
And
patients. So we've been, this is clinical care. This is gentle clinical care that now we've added, an observational study on top of this, just seeing what happens when we do this at scale. And, the technique isn't perfect. We have, somewhere between 60 and 85% hit rate for getting patients to have these vivid dreams. And I can tell you, the things that patients say upon awakening, this was more real than real. I expected to be somewhere else. Patients are having a very powerful experience.
Very vivid. It's more than just regular dreaming. And do you find that they're less anxious after or less?
Well, so what we actually, the real clincher, or what was so surprising is, just by chance, 2 patients that came through the Stanford operating rooms had bona fide PTSD. And in both cases, coincidentally, it was the loss of a child, an adult child, either due to drug overdose or suicide. Again, a horrible thing to live with for years. And, as you can imagine, nightmares about trying to save your child. Like, it's really, we didn't know this before they went to sleep. This all came up in the immediate aftermath, where putting them into these states for 10 to 15 minutes, they emerge. One of our patients, Mare, and there's a story on the Stanford med school blog now detailing her experience. She dreamt, she re-experienced the birth of her son. Instead of being a traumatic birth, it was joyful. She was reunited with her son and with her family, and they were and listening. We have a video also on our on my lab website. It still gives me chills actually to even listen to that. She says, "Thank you for this, being able to have that experience." And Mare, and Edie and the patients who tell us these things have invigorated a small army of people in the operating rooms who are now like trying, they want to do this.
But then it's transformative after the fact. Then they're less upset about these traumatic events.
She's had nightmares her entire life, and especially after this, this traumatic event. And now, what she's telling us a year later is that she has not had nightmares.
So what this tells me is that, however you get to these transformative experiences, whether it's you take MDMA and that allows you to sit with the trauma and work through it and process it, you in this sort of drug-induced dream state that allows you to sit with the trauma and process it, or the psychedelic experiences, and even these intense placebo experiences, there is something about the psychological effect of sitting with the anxiety, working through it, and however way you can. Psychedelics are a way to get there, but they're not the only way.
This woman, it sounds wonderful, but it's just one out of three. You said there's several hundred, or is most patients? Or
so
10%,
most patients.
or?
So again, we're doing this on the background of providing clinical care. So these patients,
they all come in again for other types of
surgery. They're coming in for thyroid surgeries, plastic surgery,
but they now
breast
always
biopsies.
get propofol.
So they get, and it's a cocktail, but the goal is always the same: is during emergence we are targeting a state, right? Whether we've had patients report this with sevoflurane, with propofol and remifentanil. This hits at the point. It's not the drug
itself. So that being said, though, what in terms of what we're starting to learn from the science and from these experiments is that it's not necessarily the chemical molecule itself that's having the impact on transforming these patients or people who have anxiety and mood disorders. It's the psychological experience that seems to be the most impactful therapeutic here.
And trying to understand what are the bounds, like how do we define that? Like what are the characteristics that need to be present in order for it to be transformative?
At the end of every episode, we ask a perception box question. And our question today is, what aspect of yourself are you now grateful for that in the past you struggled with or hated?
I can speak up. I used to stutter as a little child, and I went to logotherapy for like 6 weeks, and I was, I just couldn't, particularly when people were looking at me, like in this scenario. But then I sort of challenged myself and did this on purpose to get into a situation where I needed to control my language. And I don't know, because it was when I was 9 and 10 and 11, I did the sort of mindfulness training, etc. Then I managed to overcome that and use that as a way to learn how to give talks and how to convince people. So I think that this has turned to benefit.
I might even overcompensated. Sorry.
Thank you.
In jest.
So one of the things, I have a younger brother who's 10 years younger, but so for 10 years I was an only child, and I developed certain, tendencies. I was very, in my own world. And for many years, I would kind of hold ideas, and I didn't want to share them until they were perfect, and they would marinate and stew. And one day, during my PhD, something clicked. Something clicked being in a lab, and my mentor Pablo Castillo really nailed this for me. In the arguing, the joy of exposing yourself and your ideas. It takes a certain amount of courage or a jump. It's, these are things that, like my ideas, my dreams, like these are things that are really deeply special to me that, I want to hold on to and I want to kind of protect. But what I found very quickly is that by exposing them and talking, and really just tearing them apart in a way, some of them didn't survive. But, we have the saying in my lab now that, if an idea can survive this room, my office, and after talking about it for 3 hours, there might be something there.
That's the power of discourse, which I think we're losing now. A lot of people are, trigger warnings and safe spaces and whatever, but to actually be able to have, arguments and discourse.
It's also deeply enjoyable. Like you engage in this community of people.
Yeah, absolutely.
And it shifts your perspective and your ideas. So I think, I don't know if it's more superficial or not, but the first thing that came to my mind is, I used to, being an academic and being a woman, a lot of the time, and this was like, in the 90s and the early 2000s, just wasn't taken seriously if I was too feminine, like wearing makeup, dress, whatever. So I used to dislike my femininity and dress down and not wear makeup and wear baggy clothes and whatever to be taken seriously at places like Oxford and Harvard and all the, and there was this unconscious bias and stereotype. And if I would walk in to give like a lecture or a keynote, immediately expectations were lower if I was more, let's say, feminized. And so I really tried to hide that aspect of myself. And then as time went on and I got more confident and I know what I know and I know the science and I had confidence, I didn't have to pretend anymore that I wasn't feminine and I could wear makeup and dress the way I wanted, whatever, and still be taken seriously and actually take advantage of those lower expectations. Because if I come in oh, you're the keynote, and then they have lower expectations. Rather, if someone like Christoph comes in with a German accent, whatever, they're expecting him to say something very intelligent, but
he doesn't.
And then he doesn't, and it's a big disappointment. Whereas I have this great advantage where they have lower expectations, and then I can, show what I know. So I'm very grateful now for that, but that was a part of myself that I used to kind of try to downplay, and so yeah. That's mine. It's a bit superficial, but I think still meaningful.
That runs pretty deep.
Yes,
yeah.
I agree.
Well, I want to thank you, Boris, for being here with us today.
For being with us.
Thank you. Thanks for having me. This was a lot of fun.
Fascinating conversation. So if you'd like to learn more about your own perception box, spend some time this week answering the same perception box questions that we asked our guests, and check out other questions on the website at unlikelycollaborators.com. You could also subscribe to our YouTube channel and watch the show or listen wherever you get your podcasts. This has been Science of Perception Box, created by Unlikely Collaborators in partnership with Pod People. I'm Dr. Heather Berlin.
And I'm Dr. Christoph Koch. Thank you very much.